Welcome, everyone. Delighted that you could be with us today. We hope and expect the next 50 minutes or so will prove informative and enjoyable. I'm Jeremy Pirati. I'm the General Manager of Solutions for Lucem Health. And while we have titled this session Financial Improvement with Early Detection, a more fun name might have been Win 3 Ways with Early Disease Detection. And I say that because you likely will hear three important themes reflected: how early disease detection saves lives, how it reduces cost of care delivery, and how it can drive the higher margin outpatient specialty revenue that U.S. health systems depend on to fund all the other lower margin care they provide, not to mention services provided as charity or at a financial loss. Well, that went too fast. Sorry. You would think I know how to work PowerPoint by now. Okay. We are so honored to have four experts in the field join us today. I'm going to ask each of them to give their own introduction, starting with Michelle.
Hi, everyone. So pleased to be here with you today. Michelle Fortune. I am the president of Surgery and GI Service Line for Mercy Health, one of the nation's largest non-for-profit Catholic health institutions.
And Lisa.
Hi, everyone. Thanks for having me. I am the Chief Clinical Officer for About Healthcare. We provide AI-enabled solutions really to optimize that patient journey all the way from admission through progression to discharge, really to align care transitions and the clinical needs to the patients. So excited to hear more about from other experts today. Thank you.
Thanks, Lisa. Alejandro.
Hi, Alejandro Reddy, a physician executive, most recently serving as the CEO for Vivify Health, which is a remote patient monitoring business run by United Healthcare, and National Medical Director focused on implementation of various value-based care programs within the Optum and United ecosystem.
Great. And Raghu.
Yeah, hello everyone, and safe summer days. I'm Raghu Pillai. I was the interim CIO and digital leader at mHealth Fairview, an integrated care delivery network associated with the University of Minnesota. And I was the chief digital and operations officer for Currents, a revenue cycle services company. Currently, I'm the principal at Quantum Advisors, where we help businesses achieve exceptional results through organization design. Personally, I'm very passionate about designing for person-centered healthcare, so I'm very excited to be on this panel today.
Thanks so much. Thanks to all of you. Okay, so today's webinar, as I mentioned, addresses three interconnected themes: saving lives, reducing the overall cost of care, and improving the financial position of provider organizations. Any of these would be a win on its own. In healthcare, rarely do straightforward actions allow us to win in all three ways. In fact, in the US, we tend to assume that better patient outcomes will increase treatment costs, and that increased treatment costs generally penalize patients and healthcare providers. So I'm going to begin by providing a bit of context, and we'll discuss the current state realities of three pervasive diseases. And then we'll get to the more fun and interesting part where our panelists will talk about these themes from a few different perspectives, and we will finish with time for your questions. First, a little bit about Lucem Health. At Lucem, we focus on the practical and responsible use of clinical AI, and we focus primarily on early disease detection. We're very proud of our partnerships with Mercy and Mayo Clinic, and we work with providers, AI model developers, and life sciences companies from around the world. Fundamentally, we envision a world where clinicians detect problems before they become life-threatening, and where patients receive world-class care everywhere. When we talk with providers across the country, we hear a pretty consistent story. Community health systems are struggling to mediate supply and demand for healthcare services. I recall a conversation with the chief medical officer of a member of the Mayo Clinic Care Network, and he said that their most pressing need was to serve the long line of patients waiting for care. Coming out of the pandemic and the accompanying Great Resignation, too many provider organizations face pretty significant clinical staffing shortages. Patients who missed preventive care now are presenting with more complex disease. Expanding value-based care payment models are forcing attention to cost containment and organizational redesign, and all the while reimbursements, both government and commercial, are failing to keep pace with inflation. Pre-pandemic, Most health systems were operating at a 5 to 6% operating margin. In 2023, those margins topped out at about 2%. And although there was some improvement first quarter of this year, I've also seen data recently that shows that charity care is considerably higher than it was last year. So that does not bode well. So how can clinical AI solutions address these most fundamental needs? We believe that early disease detection with clinical AI provides the shortest path to driving clinical and financial outcomes improvement. For this conversation, we're going to take three examples: colorectal cancer, lung cancer, and heart failure. For colorectal cancer, despite widespread public health efforts, almost 1/3 of US adults remain overdue for screening. In fact, a few years ago, Kaiser Permanente did a study of their members and found that over 3/4 of their colorectal cancer deaths among their patient population came from their members who were not current with recommended screening. When you look at lung cancer, it remains the leading cause of cancer death in the US and abroad, partly because nearly half of diagnoses occur at stage 4. And despite the known connection between smoking and lung cancer screening rates among current or previous smokers remain very, very low. And finally, when we look at heart failure, specifically heart failure with preserved ejection fraction, which I understand the cool kids call HFpEF, the story is pretty much the same. The hospitalization rate is high, and almost half of HFpEF cases are missed, primarily because it can be very challenging to spot on an echocardiogram. Yet in each of these cases, we know that early detection saves lives. Colorectal cancer becomes dramatically more expensive to treat in later stages. Not just twice the cost of early stage cancer detection, but almost 160 times the cost of finding and removing a precancerous polyp. Discovering lung cancer at an early stage makes you 7 times more likely to survive and at 1/3 the cost. And HFpEF can now be treated with meaningful success, not complete, but meaningful success with a class of medications known as SGLT2Is, sodium glucose cotransporter 2 inhibitors. And I'm guessing that Alejandro can explain what those are. But in fact, a physician, a cardiologist who specializes in HFpEF at Mayo Clinic, Dr. Tamimi, told me that he saw that now is the time for AI-enabled detection of HFpEF, because 10 years ago, there was almost nothing to offer patients except encouragement that they exercise more and lose weight. But now new medications provide measurable protection against heart failure deterioration and hospitalization. So that's the intro, and we're going to focus on that triple win of saving lives, reducing overall costs of care, and improving the financial position of provider organizations. We're going to break it down in 4 ways, as you see here, and we're going to devote a few minutes to the discussion of each of these topics. So what I'm going to do now is start with a question to Michelle. Michelle, the screening age for colorectal cancer is now 45, down from 50 just a few years ago. And the lung cancer screening population also has grown with an adjustment in the task force, Preventive Services Task Force range for lung cancer screening. Can you talk about capacity pressure that Mercy is facing and how patient targeting is an opportunity for you to make use of limited screening capacity?
Absolutely. I think, as you've already mentioned, for many of these screening exams nationally, we're facing challenges in both anesthesia coverage and resources. And so there's now a huge pool of people to be evaluated and screened in addition to those that existed before as guidelines have changed. So really utilizing tools to ensure that those at highest risk get screened earliest is a gigantic value for a place like Mercy or other healthcare organizations. I think we all know that as you use tools that are AI driven and technology driven, you really have the opportunity to detect the disease earlier. And as you've already mentioned, that has huge impact across the perioperative continuum, in particular in GI suites and radiology suites. When we are finding that disease early and treating it early, the impact to the back end of the process is that we have those really important resources to handle complex advanced disease that must be handled. So it's been a huge benefit to us to be able to screen early with the capacity challenges that we faced.
Yeah, that makes total sense.
Jeremy, may I jump in and ask a question? Yeah,
sure.
So Michelle, I'm wondering, one of the things that I'm seeing, so I live in Charlotte, one of the things I see in my local market is that, we have two dominant health systems in our market, and they seem to be very focused on this idea of building a relationship with me and my family really early, like thinking about us not just in terms of transactional needs, but trying to position themselves as the trusted advisor to work with us throughout the stage of things, more of a life cycle approach. It would seem to me that this would fit well into something like that. I'm curious what you think about that.
Oh, I think absolutely. I've been a nurse for 32 years, and the transformation that I've seen in healthcare in the past decade really is ministries like Mercy focusing on that life cycle and a journey to health, not just a journey to some tactical interaction with you or a journey to a procedure, a journey to a visit. But really that journey to health and being there to support. And I think how does this impact that? Yesterday, I talked to a friend who is in her 40s and was diagnosed with colon cancer early, thankfully, because of some of this technology. And when you talk about that, it's a life saved. And if you help me catch cancer early, you help me detect it before I have symptoms when it can be treated easily, I'm going to be grateful for that. And I know that I really matter to you. And I think those of us who have gone into healthcare in all of the different fields that we've entered, it's to care for people. And that trend is really refreshing to see many healthcare systems starting to hone in on the fact this is really about long-term relationships and keeping people well. And this technology fits right into that.
Michelle, this is Raghu. Quick follow-up on that.
Yeah.
So you started with talking about capacity, and then you talked about how early detection really can save lives.
Yeah.
The operating reality for healthcare delivery organizations also is no margin, no mission.
Absolutely.
What are your thoughts about how to bring in early detection, early screening, and the sequelae that follows in a way that also helps grow healthcare systems and the services that they provide?
Yeah, great question. Screening programs are not always the most profitable within the real world. And while it's needed, it certainly, we want to screen everyone that we can who qualifies. But I think when you really are prioritizing to help those that are at the highest risk, you also are expanding perhaps those diagnostic or interventional opportunities. And it really makes an entire program not only more cost effective for the long term, for the patient, for the payer, for everyone involved, but it actually helps stabilize your program. And so that's really a situation where doing what's right for the patient is also beneficial to everyone in that healthcare continuum, which is a wonderful, magical thing when that happens, right? And to your point, no margin, no mission. We want to be here to care for everyone who needs us.
Great, thank you. Any follow-up questions or discussion? All right, we will move on. Thank you, Michelle. That was outstanding. We're going to move on to the second topic, which is patient throughput improvements. Lisa, among other things, you have an enviable track record as a nurse leader also, but among your many talents and experiences, you're an expert on hospital patient throughput. How does early disease detection lead to more predictable and potentially shorter lengths of stay?
So great question. And I think, that what's interesting is the goal is always to keep the patients out of an acute care facility. But unfortunately, that doesn't happen. People do end up coming in. there's still capacity issues going on now more than ever, even post-COVID. So as you can imagine, if I am a patient coming in for what I think is going to be a simple surgery, because I have hoped that I caught it early, and they go in and they do the surgery and they realize there's metastases or whatever, all of those things just start the snowball effect of now you have a longer length of stay. As soon as you add that longer length of stay, now I have a higher risk that I'm going to fall in the hospital. I'm going to get a hospital-acquired infection, all of the things that you don't want to happen. And so it's interesting because hospitals, I think to your earlier slide, Jeremy, hospitals are really trying to work at Medicare levels of reimbursement. And the more sick the patients are, the more difficult it is. They're more difficult to place. They're more difficult to really get the care that they need at the time they need it. So it's the sooner that you can detect it, even if they do have to come in for that surgery or for that treatment, obviously all the complications that you're trying to avoid in that hospital stay are going to be less if they're not as sick as a stage 4, for example.
Hey, Lisa, I'd love to hear, I know that you've worked with providers across the country. In that regard, do you have favorite examples of maybe process improvements that have worked well for earlier stage cases that perhaps did not work as well for late stage?
Perfect. So one of the technologies that we actually built was for enhanced recovery after surgery. And as you know, that's a very scripted care pathway for someone. For example, colon cancer is one of the ones that was started first. So if you can imagine, I'm in early detection. I can follow the pathway pretty easily. I'm gonna do my, post-op, my pre-op. I'm gonna get my drink I need to do. I'm gonna walk after surgery, all the things. If all of a sudden that I'm sicker when I go in to have the surgery, it's going to be much more difficult for that physician, the nurse, the patient to follow the pathway. And as soon as you fall off the pathway, you know that your results aren't going to be as good. So it's all about, following the pathway and getting the people in and out as quickly as possible. And the sicker they are, that just doesn't happen, unfortunately.
Lisa, quick add-on to that. Can you speak a little bit more about how sicker patients' discharge is much more complex and how that ultimately impacts throughput in the organization?
So unfortunately, we see this time and time again. Typically, the sicker patients are either not going to be able to go home. They might have to go to inpatient rehab. They might have to go to a skilled nursing facility. And then it's a matter of now skilled nursing facilities don't have beds. So they're medically ready to leave the hospital, but they're taking up that bed because they can't find the placement. So again, how do you have the tools to be sure that you get them out as fast as possible, but yet keeping the patient and the family in the center so that everyone really knows what that plan of care is? The goal is always to send someone home. You never want to send them to a SNF. All the literature shows the outcomes are worse. But unfortunately, if I'm a stage 4, it's more likely that even if I do go home, I'm going to need probably a lot of durable medical equipment. I might need home health. And, God forbid, I might even be on the hospice journey. So really, it's about you don't need to even think of those things if you're earlier stage detection, where I'm just like, I'm going to go in, they're going to remove the tumor. I'm going to go out and I'm going to do my follow-up as needed.
Thank you.
Raghu and Lisa, I'm just reflecting on a conversation. I'm on the board of a senior housing services organization here in the Twin Cities, and we've been having these conversations almost nonstop for the last 3 years because capacity challenges, mostly driven by staffing.
Mm-hmm.
And this is happening all over the country with skilled nursing facilities shutting down, mostly driven by staffing challenges, and how that backs up. Right? How that causes.
It backs up everything.
It backs up everything because patients can't be discharged from the hospital to skilled nursing, which means they're taking up hospital beds, which means hospitals go and divert. And so certainly it just reemphasizes that if we're able to identify disease early, you're much less likely to need that skilled nursing discharge.
Definitely.
Yeah. Great. Anything else on this topic? If not, we will move on to the next one. which is reducing overall treatment costs. So I'm going to start with Alejandro for this one. You've spent considerable time working on how to manage long-term costs of care. In our intro slides, we talked about the data on lower costs of treating early stage disease, and it seems pretty obvious, right? But when it comes to value-based care arrangements, I've heard you talk about total cost and predictability of cost. Could you talk a little bit more about what you mean by predictability?
Yeah, sure. So, I think one of your examples is colon cancer, so I can kind of maybe start there. Predictability is really more of an actuarial perspective. What's the standard deviation of likelihoods for a cost for any given patient? And I think the issue is as you get into more severe continuum of disease, the variability starts to increase a lot. And it increases because the variability of outcomes starts to increase. And the cost of therapy often tend to go up, right? So a stage 1 colon cancer patient will cost you around $50,000, $60,000 to treat that first year. Stage 4 will be 3 to 4x, depending on which study you look at. But the variability on that stage 1 patient is about 100,000. The variability on that stage 4 patient is 200 to 250,000. And even from a standard deviation perspective, but even that sort of hides the true variability in that some of these patients will end up being put on novel, recently developed therapeutics that may cost $250,000 for a treatment course or more. I think, since 2009, the average cancer medication approved by the FDA is they're all in excess of $100,000 a year. So that's one, right? Because if you have a lot of variability in spend, you just have a harder time predicting what your overall population spend is going to be, and you're more dependent on reinsurance, which is expensive in general from a payer perspective. The second thing here, though, is also this idea of durability, right? So that stage 1 colon cancer patient is only going to cost you $5,000 or $6,000 the next year because you're going to cure that patient most likely, and their spending is basically going to go down to baseline with a little bit of extended surveillance. That stage 4 patient is going to cost you $70,000 to $100,000 a year in perpetuity, basically, because we don't generally cure them. And if we do, at least temporarily, there are usually other things that are going wrong that have to be managed. So, it's a real difference in the profile. Talking heart failure was another example you brought up, and I think it's a little bit different, right? Because we all know that cancer treatment is extremely expensive in today's world. The other interesting thing, though, about heart failure and early detection is that there's emerging evidence. Not only can we treat these patients better, where previously we didn't have much to offer these preserved ejection fraction patients, but now, we're seeing complete reversal of heart failure in patients, for example, who are treated with GLP-1s for weight loss, a weight loss indication or a diabetes indication, who have early stage heart failure. We're seeing evidence of the complete reversal of that heart failure. And, the data is too early to know how long that lasts. We're just delaying it. But given these patients' overall metabolic numbers are going basically back to normal, healthy values, there's no reason to believe if they continue to stay where they're at, that they would go on to develop heart failure in the future. So I think it's a really, really interesting new era we're entering there. And there's a ton of value for us to detect those patients.
One quick question, we've talked a lot about capacity, and I think heart failure in particular is one of those populations of patients where there's a high readmission risk, right? Like they're constantly, even if they're in like a pop health type of model, it's really difficult to keep them out of the hospital, even if they're following all the things that they're supposed to do. I'm curious, is this part of that predictability of costs that you discussed earlier?
Yeah. I mean, I think the inpatient cost is a big driver of overall spending in your higher risk heart failure patients. And one thing most people don't realize is, in some of the data that I've seen in Medicare patients, up to half the patients get diagnosed upon a first admission. So that it's a crisis that tells you they even have heart failure to begin with, because they're not being detected earlier. And a patient who is admitted, I mean, you routinely see in these populations readmission rates over the next 6 to 12 months of 30 to 50%. So these patients are repeat admitters, and that's what drives an overall spend in the $50,000 to $100,000 range for some of these patients, right? Your quadruple therapy at this point is costing $500 a month, so it's not insubstantial, but it's a lot less than that inpatient spend component. The other thing I wanted to call out for you, Jeremy, I think is important is this notion. I think it was one of you who was saying that screening programs generally don't make a lot of money for providers. Well, they're also generally not super cost effective in the real world for payers. And, in an idealized environment, they tend to be, but in the real world, let's take breast cancer for example, you got to do over 20 positive mammographies to catch a single cancer. And you're doing a lot of breast MRIs on these patients. You're doing 5 to 7 biopsies on these positive mammographies. You're doing repeat mammographies. That drives a lot of cost to catch those cancers in the real world. Colonoscopy is a lot better. And the main reason it's better is that your treatment is done alongside that initial diagnostic. So, if you see a polyp, you remove it and you're done. You don't have to do anything else except send it to pathology. So I think colonoscopy's got like a modeled $30,000 per life saved metric, which is pretty good in the grand scheme. But people don't like to get colonoscopy. So you've got that 30 to 40% of the population who hasn't done it. The new liquid biopsy tests, so there's blood tests, there's stool DNA tests. Those help get your screening rates up, but their cost effectiveness is worse, substantially worse. Okay, from a payer perspective. If you're able to subset those patients and identify the patients who are more likely to have cancer among that universe of patients who are overdue, you can very quickly and rapidly improve the cost effectiveness of that overall screening program, which I think is good for society, right? Because it helps put screening in the black from a payer total cost of care perspective.
Yeah, that makes a ton of sense. And thanks for bringing that up, Alejandro. I'll just mention that I promised Oscar that we would not turn this webinar into a commercial for Lucem's products, but our colorectal cancer focused early disease detection product, which we're working to deploy with Mercy, and we've deployed at Mayo Clinic, Florida. My colleague at Lucem did a cost effectiveness analysis, because of your comments about the stool tests, stool DNA tests, and blood tests, and how inefficient those are as well. And the conclusion of the analysis that he did was that if we took our AI-enabled early disease detection solution and ran that first across the patient population to identify patients at higher apparent risk of lower GI disorders, and then for everybody else sent not the newfangled DNA test, but the less newfangled FIT, FIT for stool test, that we'd be able to find half the cancers in a population and 15% of the advanced adenomas with a colonoscopy for fewer than 6% of that population. And that takes into account the expected attrition rates of patients who might have a positive FIT but don't show up for the follow-up colonoscopy or whatever. So to your point about making screening programs more efficient, I totally agree that this is an opportunity for early detection and risk stratification. Yeah.
Yeah.
Anything else on this topic?
I don't know if other people have questions, but no, those were what I wanted to cover with you guys.
I was just going to follow up with Michelle and just ask, at Mercy, other than the work that we're doing together, how do you think about early detection supporting value-based care initiatives that value-based care programs that Mercy has entered into?
I mean, it really, early detection is critical to those approaches for us. I mean, I think we really are looking at trying to improve the health of the whole patient. And you're talking about a patient-centric model here. I mean, what's just been described and why are we launching this tool is because it really does help us reduce the cost of the total care for the patient. It improves the patient's experience. It has huge positive impact on health outcomes, as we've talked about. So it's a perfect fit in terms of value-based care initiatives when we're moving away from this fee-for-service model where we really are compensated with just the number of screens that we do. This is more about valuing the care of the whole patient, and it's a perfect fit.
Great. Makes perfect sense. All right. Last topic is on patient engagement, retention, and loyalty. Raghu, Alejandro and Michelle spoke earlier about a life cycle orientation and proactive engagement with patients. You've led patient engagement initiatives using digital tools. Can you talk a little bit about how advanced patient targeting supports those beneficial long-term patient relationships?
Yeah, absolutely. So let me start here. As consumers, what we want from a healthcare provider is a lifelong partnership to co-create health. And long-term relationships like that are built on trust, empathy, and understanding. Targeted services like additional screening for patients who may be at higher risk demonstrate a provider's attempt to better understand the individual, and the provider's actions and behaviors related to that over time build trust. Now, do patients want that? Post-pandemic consumer studies from multiple sources consistently show that over 70% of us want personalized care, are more likely to adhere to recommendations that come from personalized care because we believe that we're being better understood. And an increasing number of us are actively shopping for this experience and looking to switch providers or payers where that experience is available. Even though healthcare has historically had the data to do this, doing this at scale for N of 1 has been very difficult until relatively recently with more advances in digital technologies, where it makes it more possible today. So what I feel is we really have an opportunity, a win-win framework, if you will, to more tightly align the motivations of the patient and the provider and have healthier populations.
I'd love to just jump in and ask if you might talk a little bit about the fact we all have sort of discussed in healthcare, we're facing lots of pressing upon us related to workforce challenges and shortages. And can you maybe expound a little bit on how proactive patient engagement might support clinician engagement, clinician retention, and loyalty there? I'd love to hear a bit more about that.
Yeah, that's great, Michelle. You know, when you opened the webinar, you talked about this is a wonderful, magical thing where certain things align. When we talk to clinicians and administrators, it's clear that what healthcare providers are trying to do and would like to do is to maximize their limited resources appropriately. Meaning they want to spend more time with individuals who are the sickest and provide supportive care with less human intervention where appropriate for individuals who don't need that level of care where it's appropriate. Yes, you're right. Healthcare today is competing with talent on a global stage across industries. So using digital technologies to titrate the intensity of care across these different patient cohorts that have different needs. And in this case, I would underline not just clinical needs, but also behavioral and preference needs, actually address this issue of how do you do this personalized care and increased engagement and touch points with the patient at scale. Digital technologies can certainly decant some of those interactions away from individuals.
And that really resonates with what I'm seeing and experiencing. So thank you.
Yeah, I had a question too, and maybe I'll start with just a quick comment. You know, when I heard you talking about that sort of personal outreach, I reflected on some experiences trying to enroll people in remote patient monitoring programs. And, you know, patients are busy, and it can be a challenge to get people to pay attention to an offered benefit. And I'm maybe taking a payer's perspective here a little bit, an often offered benefit that would help them. But, you know, for a lot of these things, you typically see engagement rates in the teens. You know, you're not getting a huge fraction of your eligible population participating in these things that could benefit them. But one thing that I noted was when that initial communication was more specific to the patient's particular profile and could speak to knowledgeably about their particular risk level or issues, we did see better uptake rates. And I'm curious if you have other examples of that. You know, how that personalized communication can be leveraged to just get better engagement ultimately.
Yeah, absolutely. I can talk about a couple of examples to the degree I can disclose specific details. So in the health system that I worked before, for example, one thing that stood out, we were trying to create for breast cancer a personalized journey that would bring the patients and the care teams closer together, using digital technology, using an application to really engage, provide a continuous healthcare experience, not just when they were interacting face to face. Couple of things that came through very clearly. One was a digital divide. There are individuals who may not be as savvy or as capable to navigate complex journeys online, etc. And so simple interactions, text messages, user-friendly language to convert the most clinical, technical, scientific things to an individual, etc., were techniques that needed to be adopted. So that was one example I can give. The other example, in Minnesota, we are a large multiracial, multi-ethnic population that speaks many different native languages. And through patient advocate teams, one of the things we were able to clearly show is engagement in specific cohorts that speak specific languages and are of a particular age demographic requires different touch points for the same interaction. So ultimately, the N of one becomes really about N of one. What does that individual need? And at that point in time, as that individual ages, that framework of what the need is, the needs cloud, as we used to call it, would change. And again, digital is one way to reach them. The other way is a congruent physical interaction. So the framework I have in my mind is we think about it as an experience helix, with one strand being your digital interaction, the other one being the physical interaction, and touch points, channels, and technology being the ones that bring them together. That's ultimately what healthcare systems have to do at N of one.
Thank you.
Thanks. That's great. I'm going to invite anybody who has a question to put it in the Q&A because we've got time to cover that. And just on this point, while you're thinking about and typing in any questions that you may have, I was just going to reflect on a conversation that I had about a year ago with one of the chief quality officers at Geisinger, which has been using an AI model for colon cancer early disease detection for about 5 or 6 years now. And he said that because of their ability to engage personally with patients, and because of their ability now to say to those patients, we've done a personalized review of your record, and it appears that you may be at higher risk for certain intestinal problems. The best way for us to figure out whether you actually have something going on is for you to come in for a screening colonoscopy. He said he had spent 4 years at Geisinger with all sorts of traditional methods of trying to encourage colonoscopy participation. And he said nothing we did moved the needle. But when they contacted patients, and they've published on this in the Catalyst Journal, when they contacted patients with this personalized message, 70% of the patients agreed to come in for a screening colonoscopy, which was unheard of. So he said, we keep at it because we're seeing results that we haven't previously seen before. And it's that personalized interaction with patients, that personalized engagement. So go ahead.
Jeremy, I mentioned in the value-based care space, right? Quality metrics are becoming increasingly important to your financial outcomes. They create hurdles for payment. And everyone is kind of standardizing on an increasingly narrow set of most important measures. And screening are typically on that list of very important measures. And it gets harder and harder to beat the norm and to get into that top quintile of performance. And so, I see stuff like this as being kind of killer apps to help people not just be an average performer, but be at a top quintile performer where you get those big performance multiples in your value-based care contracts.
Yeah, that's a great point. That's a great point. I don't think we've had any questions come in yet. So while people think about it, any final questions they may have or initial questions they may have, I was just going to start by thanking our panelists because really appreciate the perspective and the real world expertise that you brought today. And it's been just a delight to work with you as we've prepared for this. So thank you for your time and for your generously giving of your enthusiasm for the topic and of your passion for improving healthcare. I think we have one question that just came in, which is great. I'm reminded that we're always supposed to have a shill in the audience, and anyway, and we don't have. We missed that step. But somebody put in the chat, sorry, the Q&A isn't accessible. Apologize for that. Question is, what are some of the metrics for quality of care? And from a payer perspective, what are the benefits and obstacles to embracing early disease detection? Alejandro, do you want to start with that?
Yeah, so, in this regard, there are metrics for screening for some of the major areas where we do screening. We feel like screening is important. So breast cancer, colon cancer, cervical cancer. And sorry, the second part of the question was just what are the obstacles to early detection? I think screening is always challenging because it's logistically difficult to get people in when they're supposed to come in, right? It's not something that people generally seek out care for and keep on top of. And providers are busy, right? And so of all the things you're going to deal with in a day, chasing down people who are overdue for screenings is typically one of the last things you have on the list. So I think number one, providers who have a process, just a process for doing this that is freestanding generally do better because it doesn't slip through the cracks as much. But that costs money, right? And you've heard from some of the other panelists that these programs aren't generally profitable. So it's unlikely, and most providers don't deploy capital to build these special, robust programs to keep people coming in the door. Maybe unless it's an important quality measure that's in their contracts and they focus on it. And then of course you kind of build infrastructure around it. But I think the second big problem, right, is you've heard the way to do this right is to know something about the patient and the patient's risk level and don't send out a generic reminder, but to have it be very specific to the patient and ideally be delivered by a provider. So it's personal, and we all know that when a doctor asks you to do something, you're much more likely to do it than when you get a random voicemail from someone. So how do you build in the infrastructure to actually know what that patient's risk level is, and keep that updated and use that and connect that to your whole marketing apparatus in a HIPAA compliant way to then reach out to that patient. It's ultimately a clinical outreach. It's not a marketing outreach, right? I think that's the key difference. So, Jeremy, I know you guys have thought a lot about that, and I just think you can't underweight the importance of the logistics there, because it's easy to do in concept. It's just the logistics get in the way.
Thanks. I think that makes perfect sense. And from a payer perspective, in the commercial side of the insurance world in the United States, there's this maxim that commercially insured patients generally turn over. They move from one insurance provider to another about every 18 months. But in the Medicare Advantage world, which is half of Medicare enrollees now, that is more like 3 years. And in a significant number of Medicare Advantage programs, there are provider groups that are multi-specialty provider groups that are themselves taking on a global capitation payment for that patient. And they are emphasizing long-term relationships with those patients. And so for those groups, they are holding on to patients for 5 years or more as being the primary care provider and the primary financial risk agent for that patient's healthcare. And so thinking about our discussions about, again, let's go back to colon cancer, where if you're able to identify colon cancer at stage 1 and you have a predictable cost in the first year of $50,000 or $60,000, I think you said, Alejandro, but then you have predictable discharge, as Lisa spoke to. As Michelle spoke to, you've established then a lifetime engagement with that patient. And in the subsequent years, you have very predictable, manageable costs for that patient. And so that's another example of, from a payer perspective, from an entity that's bearing financial risk. Sometimes there's a maxim that, well, we'd rather have somebody else discover what's the chronic or serious illness once the patient is off our books and onto somebody else's books. But in many cases, in the Medicare Advantage world and globally capitated provider group world, you're going to have that patient, you're going to have a long-term relationship with that patient, and you want that long-term relationship. So early detection actually becomes very important from a financial standpoint.
Yeah.
And really quickly, sorry to interrupt, Alejandro. Jeremy, we do have a few questions in the Q&A as well that are ready.
Okay, excellent. Thank you. And I missed those. Question about future role of active implanted devices. Think of a Smart Knee by Canary Medical. Any of you have any insights on implanted devices and how those can enable early detection of complications down the road?
Sorry, what was the name of the one that was mentioned?
A Smart Knee by Canary Medical.
I'm hearing early information on a lot of those tools, and I think, like you, we're investigating further how that might benefit our patients, either to improve health and wellness or alleviate suffering. So I really don't have a lot of commentary today on it, but I think it is a really interesting emerging part of our care delivery model that we're all watching right now and trying to determine the best next steps.
Yeah, I will add, coming from a remote patient monitoring background, that sort of thing is the crux of what that technology tries to do. And I will say that, the benefit of these smart implantable or devices that are designed to collect biometric data on a much more frequent basis is it gives you more data to work with. And you absolutely, and there's no question that it helps you detect issues, potential decompensations, changes earlier. I think what is not nearly as obvious is whether that's happening in a cost-effective form and manner, because these things tend to be expensive, and You really have to look carefully at what are the outcomes you're trying to detect earlier, and in real world use, how effectively can you actually intervene in a manner that generates a better outcome. I think in general, these things have to, my personal opinion is that they have to be tied with advanced algorithms to kind of sort through the information, because if you're requiring a physician or a highly trained nurse to look at the data and decide whether they need to do something about it, that almost always kills the economics of these types of initiatives. So there's a couple of thoughts. So I definitely believe in it, and I think it's gonna create some really interesting opportunities. One of the ones I think is the coolest, we're talking about cancer, is smart catheters in patients who have central catheters in an ambulatory setting. Some really interesting data coming out. These are very high-risk patients. Very bad things happen to them when things go wrong. But they're expensive, right? And they're not widely used today.
Sure.
I think you're so right. Looking at the clinical benefit that comes out, like the smart knee technology, if you're doing a knee implant, really understanding what the clinical benefit of that additional data will be is going to be important.
And I think that's part of engaging the patient, right? It's another tool that you can use to keep the patient engaged and have them be like a lifetime patient of your healthcare system.
You're empowering them, really.
Right.
Yeah, great points. Another question that came in was about early disease detection solutions in a fee-for-service environment. We've talked some about value-based care environments, but how would these solutions work and be beneficial in a fee-for-service environment?
Well, we're sort of in both environments within Mercy. We've got fee-for-service, we've got value-based care arrangements, and I think it's the same benefit in both worlds. On the fee-for-service side, as we talked about earlier, when you have large groups of patients that are really needing to be screened, and you're able to use this AI-enabled technology to hone in on those that are higher risk, you really end up having a program that is a lot more heavy on diagnostic and interventional, because you have people coming in that are screened, and to the point earlier, then you find polyps, then you need to take action. So you really are, I think, in both worlds, seeing improvements for the patient, for the payer, and it's the right thing to do.
Michelle, in fact, I was speaking with one of your colleagues yesterday, Dr. Jay Carlson, and he mentioned that at Mercy, they have modeled out financially that Mercy will be able to hire additional nurse navigators to do improved patient outreach, funded by the additional top-line revenue that will be generated by more efficient screening.
Absolutely. Yeah.
Great. The last question, two more quick questions. One was, and this might be for Alejandro or Michelle or anybody, but is there a risk that innovative screening can improve outcomes but make your published measures look worse?
I'm curious what you think, Michelle, about that. I think it's actually the opposite, because it tends to be your late stage patients where you have misadventures and where you're going to have, I mean, if you're talking about like surgical outcomes and that sort of thing, you always want to have an earlier stage, simpler cases, and early detection really does drive the mix that direction.
That's exactly what I was going to say. I mean, I think it is the opposite, where when you are finding these things earlier, that interventions from a surgical nature are much less complex, much more straightforward, and the patient outcomes are just so much better. I mean, if you have advanced disease and the surgery is just wildly complicated, there's so many more opportunities for variability and challenges for the patient. So I think we've seen the opposite of that. It helps.
I could see in an ACO or payer reporting environment where there's a risk that innovation actually makes the desired quality measures inadvertently look worse. And so maybe this is an opportunity for education of those regulators and of those quality setting organizations where okay, we've got hard data now. We've shown that you can actually improve the screening, you can improve the efficiency of screening, and so it should be we should not only look at, we have an opportunity to not only look at the screening rates themselves, but also the expected percentage of complications or disorders that we're finding as part of screening.
I think that's a great point. I mean, as innovative technology emerges and we get data, we really do have to educate regulators, legislators, and that way we're not inadvertently capping out technology growth in areas that will achieve what we all are trying to achieve, which is whole person health.
And I think to your point, Michelle, we also, how do we loop the patients into that education so that they're smart consumers? Because if they're reading something that is to the contrary, it could almost turn them off from the goal at hand. So
Absolutely.
I think it's the full scope of everyone needs to be educated.
Yeah.
The last question that we had is this should have been my shill question, right? Are these solutions affordable for health systems? If you're interested in learning about the financial modeling for these, I'm happy to spend night and day talking about that. Michelle is nodding because we've spent a lot of time working with Mercy on the financial modeling, and our view at Lucem is that they have to be affordable, and in fact, these solutions have to drive financial improvement. We live in a world where driving improved patient outcomes isn't alone going to be enough to enable health systems to adopt new information technology. So let us know, follow up with us here at Lucem if you want to learn more about that. But I want to close now. We went a little bit longer than I thought, but the questions were so good and the answers were so insightful that I didn't want to cut it off. Michelle, Lisa, Alejandro, Raghu, thank you so much for sharing your time and expertise. To everybody who joined us, we're so thrilled to have you. We will have a recording of this available so you can share it with your colleagues who weren't able to join. And of course, any follow-up questions, just get in touch with us here at Lucem. Thanks so much and have a good afternoon.
Thank you.
Thanks, Jeremy. Thanks,
Thank
everyone.
you.
Bye.